So, dear friends, welcome once again to our Critical Care Sunday webinar. And after a short break of a few weeks, we'll be starting again. So, today there's a case presentation from Health City ICU, Department of Critical Care, Guwahati. And this has been enabled by Dr. Reshu Gupta, who's the HOD there. So, we thank him for this. And it will be presented by Dr. Rajdeep. He is the IDCCM trainee in that ICU. And also joining us for the discussion will be Dr. Raki Baru. She is a consultant in the ICU in critical care. So over to you, Dr. Rajdeep.
Thank you, sir. Good evening, Bansal sir, Reshu ma'am, Raki ma'am. Today I'll be presenting a short case, a case that was presented in our ICU in a very critical state, and prompt management was very much essential in ultimately saving the life of this patient. So I'll start. So a 28-year-old female patient who was a housewife by profession, belonging to the low socioeconomic strata, presented to the emergency department of our hospital with the following complaints. She presented with fever for 7 days, one episode of abnormal jerky movements of the body 7 days prior to admission, and generalized weakness. She had been previously treated at a tertiary care hospital for a period of 4 days since the onset of symptoms with IV antibiotics, steroids, and antiepileptics as a case of meningitis with anemia and thrombocytopenia. She had been shifted to our center due to non-resolution of the symptoms. In the earlier hospital, she had previously received 3 units of packed RBCs and 4 units of random donor platelets. On detailed history taking, it was found that the patient had a past history of jaundice and anemia following a medical termination of pregnancy 3 months prior. There is a history of herbal medication for the above intake of herbal medication for the above complaints, with the last intake of herbal medication 1 day prior to admission. She had an lower section cesarean section 9 years back, following which recovery was uneventful. And she also, the attendants also gave a history of the patient being a diabetic for the last 2 years without any treatment.
So that is the history.
Yes, sir.
So just go back to the first slide.
Yes, sir.
So, one thing I would like to know here is what is the sensorium in the previous hospital?
The sensorium in the previous hospital, she was maintaining a GCS around 12 and 13 out of 15. That is E3, V3, M6.
So there was altered sensorium, fever, altered
yes, sir.
seizure.
Yes, sir.
The other thing is both fever and seizure occurred simultaneously, or fever was persisting for much longer and then she had a seizure?
No, sir. The history, according to the family members, was that the fever occurred first, and within 6 to 12 hours, there was an episode of seizure.
Okay, okay. So apart from this, you have said that she was taking herbal medications for jaundice and anemia at MTP 3 months ago. So if that had not resolved?
No, sir. No, the patient had taken herbal medication for the other complaints for the last 2 and 3 months, but the last drug intake was 1 day prior to admission, 1 day prior to the event of his fever.
No, but if this had resolved after the MTP, then why was she taking the herbal medication?
So I really
okay. But then the other thing is one thing you have missed out in the history is very important. When you take the drug history, it is very important to find out what drug she has taken.
Okay.
Because this is bearing on what drugs we use. You understand?
Yes, sir. But sir, this is something of a quack medication from the rural. So
okay, but when you give any exam, etc., you should always mention this because this is very relevant because we often end up using antibiotics. If she has received those antibiotics before and she has not responded, we will not use those antibiotics. Right.
Dr. Bansal, in this side, the quacks, they give something, they mix in a bottle. It's a liquid sort of a medicine, and then they are asking to take there, or it's sort of a powder which they give. So
Okay.
even the people, the general public will not be aware what exactly it is.
No, that is fine. But just, if she's coming from a proper hospital, then it becomes very relevant. If suppose
Yes.
President azobactam or a carbapenem, then she's not responding, we will not use those antibiotics. We will probably use something else. That is what I was trying to say. So here, history is relevant in the sense of medication because she's on herbal medication. She has received some quack medication, and so those things become very important. So coming to this history, Dr. Rajdeep, why do you think she had a seizure?
Uh,
Or what do you
so,
think of fever, altered sensorium, and seizure? What diagnosis would you think?
so the first diagnosis that usually comes to mind is a CNS infection, sir.
What
Uh,
sinus infection?
it can be bacterial meningitis,
Okay. Anything else?
and it can be any meningitis, that is, it can be bacterial, viral.
So when you say viral, you want to say anything specific? Viral meningitis.
Sorry, sir.
When you are saying viral, do you mean viral
Yes,
meningitis
sir.
or something more than that?
Without any
It's a
confirmation,
viral encephalitis. Huh?
viral encephalitis. Yes, sir.
Yeah,
Viral
viral
encephalitis.
meningitis is a mild kind of a disease. It does not result in so many symptoms. You have to think of viral encephalitis. Huh?
Encephalitis.
Anything else?
It can be because of liver injury, for drug-induced liver injury. It can be due to hepatic encephalopathy as well. Patient had jaundice. She was taking herbal medication. She developed fever. She had altered sensorium.
So hepatic encephalopathy is one possibility. Huh? You think she may have hepatic encephalopathy? She had,
Yes.
but we haven't come to jaundice. You have not told me she had jaundice yet. So you
No, sir.
what
She
she
had.
has just now. That maybe that you will tell later. So
Yeah.
is there any other differential diagnosis when you think of meningitis, infections? Is there any other infection which can cause fever, altered sensorium, and
Malaria, cerebral
very
malaria.
good, very good. So you have to think of tropical infections, malaria. What else? So you can have scrub typhus. Scrub typhus can also present like this.
Okay, sir.
Encephalitis and even leptospirosis. Huh? So
Okay, sir.
tropical infections have also to be considered. Okay. So next slide. Now she has anemia. Well, just hold it there. Now go back.
Yes, sir. I'll go back, sir.
Yeah, last slide. Anemia 5.5 and thrombocytopenia 30,000.
Yes, sir.
This anemia is long-standing or acute?
So this was the report that was given to us from the previous hospital. So I'm not able to say at this point that the anemia was long-standing or acute.
No, but do you think you can get an anemia of 5.5 in a normal patient in 1 week's time?
No, if there is no evidence of acute blood loss, no, sir.
Any other reason why you can have acute drop of anemia in critical illness? This is bleeding, you said. Patient can bleed and they get a drop of hemoglobin from 12 to 5.5 in a week's time.
So,
Condition?
so there can be a UGI bleed, underdiagnosed UGI bleed going on.
No, that is fair enough. Any bleeding can cause.
Yes, sir.
The thing is, Dr. Raki, any other condition which can lead to acute drop in the acute ICU setting or acute illness?
So in the event of any sepsis, like in gram-negative sepsis, we may have upper GI bleed that might lead to severe
Okay,
anemia.
whatever.
And hookworm infestations also.
Hookworm will not lead to
acute drop. Yeah.
GI, see, bleeding is one thing. Any other pathology which can lead to acute drop of hemoglobin. Supposing the patient in the ICU and within 1 week you see the hemoglobin has dropped from 10 to 5. One is bleeding. He can be bleeding anywhere, whatever the cause. Is there any other cause of acute drop of hemoglobin in the critical setting? So it is hemolysis. If the patient starts hemolyzing because of whatever reason, so the common conditions can be either drug-induced hemolysis or autoimmune hemolysis, blood transfusion-related hemolysis. So there are many causes, but hemolysis and GI bleeding or bleeding from anywhere are the two causes of acute drop of hemoglobin in the ICU. The other condition is, like you said, sepsis or condition with surge, especially sepsis, when the patient first gets admitted to the ICU, there can be a drop of hemoglobin of 2 to 3 in the first 1 to 2 days. This is because of two reasons: because of cytokine mediated increased destruction of the RBCs. And the second is the lot of blood draw that we do in the first couple of days for these patients. So hemoglobin can easily drop from 12 to 9 in the first 2 to 3 days in the ICU patient. So these are some of the causes of acute loss of hemoglobin or blood in the critical care setting. Okay. So Rajvi, next slide. So now, Rajbir, we have fever, altered sensorium, and we have seizures, we have anemia, we have thrombocytopenia. So, can the patient have sepsis in the brain going on? No, we didn't talk about sepsis. Can fever, altered sensorium, and seizures be because of sepsis?
Yes, sir.
Hmm?
CNS infections can present with this
No,
same picture.
one is CNS, outside CNS. Supposing there is a UTI, just suppose
Yes, sir.
any extra CNS site of sepsis, and
Yes, sir.
so if the brain is, can the brain be involved in sepsis?
If there is associated hypotension and the brain goes into hypoxic state, they may present with seizure.
No, what else? What do you? Is there any other way in the brain can be involved in sepsis? In supposing there's a pneumonia with sepsis, UTI with sepsis, can the brain be involved if there's no hypotension?
In a case of severe sepsis, septic encephalopathy,
Yes.
the patient.
So it is called septic encephalopathy. Yeah? So why do you get septic encephalopathy?
Because of the disease process, the brain, there is a imbalance between the pro and anti-inflammatory cytokines in the brain, which may
okay, cytokine mediated. Fair enough. And whatever metabolic disturbances are occurring. Very good. So can you get seizures in septic encephalopathy?
Yes, sir. They may present, although rare.
Okay, very good. So you can get seizures. Those seizures is generally, something which occurs more with focal lesions, but diffuse septic encephalopathy can also result in seizures and some focal signs sometimes. So septic encephalopathy is another differential. So that is also to be kept in mind. She has thrombocytopenia also.
Yes,
so
sir.
These are some of the differentials. She may be having CNS meningitis. She may be having viral encephalitis. She may be having septic encephalopathy. She may be having a tropical infection. She may be having a hemolytic anemia with thrombocytopenia, though that does not entirely explain the CNS symptoms. And of course, there's a very strong history of this herbal medication and coag medication, which may be contributing. Can herbal...
Dr. Rajdeep, can stroke be in the differential diagnosis with this?
Dr. Reshu, the problem with stroke is, the fever came before the stroke.
Yes.
So, there can be, some conditions can lead to fever and secondary stroke is possible, but remote, and there's no focal abnormality as such. That is from whatever he has said. So that is the problem with stroke. That's why I did not bring stroke into contention. So Dr. Rakhi, any comments you want to make?
So we'll also have to take into consideration the electrolytes also regarding the fact that the patient had seizures. So like whether the patient had any...
So that will come with the investigation, right?
Yeah, yes, sir.
Whatever we have. So this is how the case is unfolding. So we have to take it like this. When the patient comes to you, you have taken the history. So what is your approach? This is the thought process. So as a resident, you're evaluating, as a consultant, you're evaluating. So you have taken the history. So these are the differential which come to your mind. So because you have to formulate a differential and then a plan to treat the patient, especially when you're alone, and you have to do these things. And also from the point of view.
And moreover, sir, with any history of fever and altered sensorium, we'll have to keep the suspicion of any for TTP very high.
Yeah, so
with fever and sir altered sensorium, so we have to keep the suspicion for any TMA very high. So we'll have to side by side. We'll have to do the investigations for those thrombotic microangiopathy.
Yeah, but
features
though
also.
that is a very rare condition. So if the investigations point towards that, that we can think of. But
Yes, sir.
definitely it can be kept in consideration, but it is a very rare possibility.
Yes, sir.
First, common things occur more commonly, we have to think of those. And one more question for you, Raki. What are the three common causes of, or rather the commonest causes of altered sensorium coming to the ICU? You know, if your patient just comes with altered sensorium, what three common conditions will you think of?
So patients, patients with septic shock, they come with septic encephalopathy,
One,
or
okay.
patients with metabolic encephalopathy, usually CKD patients, or so CLD patients with high levels of
Okay,
ammonia,
so
they might come with
one is
metabolic encephalopathy,
encephalopathy, yeah? It can be septic encephalopathy, it can be metabolic.
metabolic encephalopathy.
Any other common condition you will think of, which is the most common condition of a patient coming to the ICU with altered sensorium?
Drug overdose, sir?
No, no, drug is a little overdose. That is also a common. Anything else? Stroke, huh? So stroke very kept in mind. So the commonest conditions coming presently with altered sensorium are stroke, septic encephalopathy, and metabolic.
Encephalitis. Also, encephalitis is also common, seasonal maybe.
Yeah, encephalitis is also common. Okay, so encephalitis and even poisonings also, like you said. Okay.
Especially in our side here, the encephalitis is very common. So Japanese encephalitis and herpes simplex encephalitis, very common in the northeastern part of India.
Okay, fair enough. Next.
Next slide, sir. Okay. So after the history taking, the patient was examined and the following findings were seen. The patient had a resting heart rate of around 112 per minute with a NIBP of 130 by 80 millimeter of mercury, SpO2 of 98% with 3 liter of oxygen via nasal prong. She was icteric, pale, tachypnic with a respiratory rate of 22 to 24 beats per minute in an altered mental state with a GCS score of 11, that is E4, V2, M5, and with multiple ecchymotic patches over the limbs.
So why do you think she's having ecchymosis?
So because of the thrombocytopenia that was previously recorded.
Okay. So when you see this ecchymosis, would you like to consider any other test important?
For this patient, sir, I'd like to go for a coagulation profile, sir.
Yes. So the PT-APTT also has,
Yes, sir.
especially we are considering liver disease.
Yes, sir.
Disease prothrombin time is grossly prolonged. So we have to look at PT-APTT also. Now coming to the respiratory rate, why do you think the respiratory rate is increased? Saturation is normal, I believe, right?
Sir.
Huh?
Sorry, sir.
Saturation.
Yes, sir. Saturation was maintained at 98% with a 3 liters of oxygen via nasal prong.
So essentially, saturation there was no problem. Yet the respiratory
No problem.
is high, right?
Yes, sir. So
Why is the
probably because of the anemia, sir.
Okay, one reason is anemia. Any other reason?
Because she is in an altered mental state, sir. So
okay, very good. So you know, whenever there is a CNS pathology, because the respiratory center is in the medulla, often CNS pathology leads to increased respiratory rate, and especially patients with sepsis, septic encephalopathy, they have a higher respiratory rate and respiratory alkalosis. And the other any other reason why the respiratory rate is high?
she might be having she has an alternate mental state, so she might be having micro aspiration. So there may be some sort of
micro aspiration will not lead. The other thing is fever. You said fever. Fever increases.
Yes,
Huh?
Yes, sir, fever.
So that is why the respiratory rate is high. So next slide.
Okay. So on systemic examination, it was found. So the respiratory system, it was found that the breath sounds they were equal vesicular breath sounds bilaterally. The chest was clear. The cardiovascular system, they had normal heart sound without any added heart sounds. The abdominal examination was soft, non-distended, non-tender with no palpable organs. The central nervous system examination revealed a GCS of 11 by 15. Pupils were equal and reactive. There was no neck rigidity, and bilateral plantar responses were equivocal.
So now after doing this examination, can you
Yes,
do
sir.
meningitis?
Sir, since there is no neck rigidity, probably yes.
So is neck rigidity always present in meningitis?
No, sir.
So you cannot rule it out.
Yes, sir.
You cannot rule it out. Okay. So apart from this, one very important clinical symptom you have not told me, which is relevant to encephalitis and meningitis. What is that? What is the triad of meningitis?
Organ sensorium.
Fever, headache, and neck rigidity. Yeah. So you know anything about headache?
The patient is
Okay.
in an altered mental state, so she could not comment on her
No,
headache.
no. You have to take the history from the relatives also. She was having, because headache is very significant in meningitis. Before the
Yes,
patient
sir.
go into altered sensorium, she would have complained about headache.
Headache.
Right. That's okay.
Okay.
So now, you know, she was given steroids. Huh?
Yes, sir.
Right. For presumed diagnosis of meningitis or viral encephalitis, is there any role of steroids in meningitis?
Yes, in bacterial meningitis, yes, sir, but no role in viral encephalitis syndrome.
Okay, that's very good. But role in viral encephalitis, you can say that. But what is more correct is that if the patient is not responding in the first 4 days and you have proven viral encephalitis, you can try dexamethasone. Huh? So
Okay, sir.
you can say that also. There is no proven rule. That is absolutely right. The evidence is very flimsy. So
Okay,
Dr. Ishu and Dr. Rekha, Rakhi, whenever you want to comment, please feel free to comment. Huh? So apart from this, you know, what else do we have? So we are basically at the same situation. The examination has not helped us, right? Huh?
yes, sir.
Okay, carry on. Next slide.
Uh, so the initial set of investigations that were sent from the ER revealed the following: a hemoglobin of 7.6 gram per deciliter, a TC count of 13,500, a platelet count of 23,000 per cubic millimeter mercury, with a urea level of 52, a creat of 0.7, a raised bilirubin, total bilirubin level of 3 milligram per deciliter, with a raised indirect bilirubin of 2.5 milligram and direct bilirubin level of 0.5 milligram per deciliter. The SGPT to SGUT was 83 and 46 respectively. The PTINR is 13 and 1.15, an RBS of 156 milligram per deciliter, serum TSH of 1.11, sodium level of 137 millimole per liter, potassium of 3.7, HbA1c level of 5.1, and a TROPI of 0.015. The
Okay.
ABG was
So
coming.
leave the ABG for the time being. So now let us
Sir.
interpret the investigations. So
Yes, sir.
how do you interpret the TLC? Does that mean that she has infection, sepsis?
Probably, sir, but it's very confounding at this point because the patient had previously received some doses of steroids, sir. So it can be a reactionary thing as well.
Okay, very good. So steroids can cause elevated TLC, and a lot of patients in our ICU get steroids. So that should always be kept in mind. And apart from that, you know, there are many conditions, non-infectious conditions, non-sepsis conditions, which can elevate the TLC. So high TLC at presentation does not mean sepsis all the time. That's very important. Now,
Yes, sir.
platelet count you have already told is decreased. So when you see a low platelet count, platelet thrombocytopenia can be broadly classified in 3 groups in terms of its etiopathogenesis. You know why there is thrombocytopenia? Of course, there are multiple causes, but 3 broad categories. How would you approach these 3 categories, or what are these 3 categories?
Opinion. One can be drug induced.
No, those are specific causes.
Okay, sir.
All broad categories. Like there is a production and there is a consumption, there is a destruction.
So one can be due to impaired bone marrow function.
One, very good. Increased
Okay.
decreased production.
Yes.
One.
Yes, sir.
Then
So the other can be consumptive.
okay, increased consumption.
Yes, sir. And the other can be dilutional as well, sir.
Okay, so dilutional. So
Yes, sir.
dilutional is then you know dilutional is something. Okay, dilutional also can be considered, but the 3 categories.
Destruction.
Huh?
Destruction of the platelets
Destruction,
also due to
absolutely.
antibodies. Yeah.
So increased consumption, decreased production, and increased destruction. These are the three broad categories, and then you can go further in this. So when you see a low platelet count, what one investigation you should do, which is really helpful.
Investigation.
So you should do a peripheral smear.
Peripheral blood smear.
It is very helpful. One, it gives you the correct count, manual counting.
Okay, sir.
And then it tells you if there are large platelets. If there are large platelets, it means production is good because those are early platelets, immature platelets which are being released. So that means production is good. And the third thing is it tells you other things also. So platelet, you should always send a peripheral smear. Now coming to urea creatinine, urea is slightly elevated, creatinine is normal. So what is your
Yes, sir.
take on the bilirubin, Dr. Razi? What is going on with the bilirubin?
So the total bilirubin is raised, but indirect bilirubin is raised more compared to direct bilirubin. So probably there is some sort of event where the liver is not able to conjugate the bilirubin level. So I probably think there is some sort of increased hemolysis in this patient.
What will you call this kind of jaundice? This jaundice, right?
This is unconjugated hyperbilirubinemia.
Sorry?
Unconjugated hyperbilirubinemia.
Correct. So when do you say the patient has unconjugated hyperbilirubinemia?
When the indirect bilirubin rises more compared to the direct bilirubin.
Is it just rises more or do you have some specific values for that? If supposing direct is 40%, indirect is 60%, does it become unconjugated hyperbilirubinemia? Dr. Lucky? So you said indirect or unconjugated hyperbilirubinemia when it is more than 85% of total bilirubin. That is the definition. Not just indirect is more than direct. That is the strict definition. And when you do it from the lab, sometimes the lab instruments are not very precise. So you may not get 85%. But anything, which is significantly high is indirect. So that is what is indirect. So if you get indirect hyperbilirubinemia, then you have to look at hemolysis. The commonest cause in the acute setting is hemolysis. There are a couple of other conditions also, but relevant to this is hemolysis. So this would indicate hemolysis, Dr. Rajdeep, like you said?
So with the low hemoglobin level, probably say yes.
Okay. But the hemoglobin, we don't know whether this is chronic anemia or acute anemia yet. But
Yes, sir.
there is hemolysis going on.
We'll have to look into the reticulocyte count also.
Yes,
And,
very good, very
maybe
good.
Maybe the LDH levels and the haptoglobin levels.
So reticulocyte site count, what happens in hemolysis, Dr. Raghi?
That will increase.
Okay. So if there's hemolysis, the will increase. So we should send the retic count. So again, we need a retic count or a peripheral smear of the blood. And the other thing is now coming to HGPT. So HGPT is increased.
Yes, sir.
Maybe there's some liver involvement.
Yes, sir.
Coming to INR is normal, RBS is normal, so there's no diabetes. You said HbA1c is 5.1, sodium potassium is normal.
The acute liver failure part can be, sir, like excluded because the INR level is less here, less than 1.5, according to definition.
So acute liver failure, what exactly are the features in favor and against acute liver failure?
Usually, development of severe acute liver injury with an INR of more than 1.5 without any previous like history of cirrhosis or pre-existing liver disease. And I think that presents less than 24 weeks of the event of any acute insult.
What are the two symptoms, main symptoms of acute liver failure?
Hepatic encephalopathy, hyperbilirubinemia.
So a patient presenting with altered sensorium and jaundice, these
Jaundice.
are with a supposedly increased INR.
INR of more than 1.5.
Yeah. So, but the thing is, these patients, the INR, that's the classic definition, and INR is usually elevated, but some people now say that the INR is not a perfect test, and because there can be variability, so INR may not always be increased. But you are right, absolutely. The classic definition and teaching is 1.5 INR. But very important also is the HGPT-OT. You know, if you have acute liver injury, you will not get 83.
Very high.
Yeah, it will be much higher than that. So acute liver failure is practically ruled out. And the other thing is, in acute liver failure, bilirubin will be direct or mixed.
Direct. Yes.
So acute liver failure goes to the dustbin. The diagnosis is not good. So rightly pointed out by Dr. Rakhi. And now we come to the ABG. So what is the ABG diagnosis, Dr. Rajdeep?
Sir, the ABG more or less appears normal, but there is slight evidence of hyperventilation in this patient. There is mild respiratory alkalosis.
So respiratory alkalosis only or something else also?
We compensated.
What is normal bicarb in the ABG?
Normal bicarbs are 24.
So is this elevated?
Yes, sir, it's elevated. So there is compensation as well.
Your patient was tachypneic, right? Maybe
Yes, ma'am.
this is alkalosis.
What is the ABG diagnosis, Dr. Rajdeep? Again.
So the diagnosis is going to be respiratory alkalosis with metabolic alkalosis.
Yes, there's no compensation. There's a combined alkalosis.
Yes, sir.
Okay. So when you have a PCO2 of 34, you expect compensation. So in compensation, bicarbonate should decrease.
Yes, sir.
So respiratory alkalosis is occurring because there is a hyperventilation, right?
Yes,
so why
sir.
is there a metabolic alkalosis?
Probably because the compensation has not, the patient has now reached a point of no compensation, and the body is
normal
like
bicarbonate is 24.
24. Yes, sir.
Metabolic alkalosis.
Yes, sir.
What are the causes of metabolic alkalosis? Do you think like that? What are the causes of metabolic alkalosis, and what is relevant to this patient? Which of those?
The raised urea level, sir.
How does raised urea lead to metabolic alkalosis? You're somewhere there, but you have to be more specific. What is the classification of metabolic alkalosis? Metabolic alkalosis approach is divided into two groups. What are those two groups? Dr. Rakhi, your comments? Metabolic alkalosis.
So maybe due to some extrarenal loss or due to diuretic use, maybe.
We have not used diuretic, but we have used certain drugs.
Drugs were used.
Which drug? We have
Can
used
you
some
go-
drugs.
Steroids were used
Yes.
previously.
Yes.
Yeah.
So steroids cause metabolic alkalosis.
Metabolic alkalosis.
What other thing can possibly be causing metabolic alkalosis? One more thing. Hypovolemia.
Hypovolemic.
Patient may be hypovolemic. And when there's hypovolemic, there's increased aldosterone secretion to retain sodium and water that compensate for the hypovolemia, and aldosterone increase causes metabolic alkalosis. So, Dr. Rakhi, any comments on the approach to metabolic alkalosis? Metabolic alkalosis is divided into two groups, and to determine, what kind of a response to therapy these patients would have, we like to do one test. What test is that?
So,
see, when you have a patient with metabolic alkalosis, so the approach to metabolic alkalosis is either you can just say this is because of this, steroids will rise, so it's because of steroids. But sometimes it's difficult. So there you have to actually go step by step. So metabolic alkalosis, then you divide into two groups.
Yes, sir.
You do one test to see what is the cause of metabolic alkalosis, and then you determine your therapy. So anybody wants to tell me how do you approach metabolic alkalosis?
Sir, I'd like to go for a urine chloride level.
Very good. So what do you get? What information you get?
Sir, the alkalosis can be of two types. It can be chloride responsive or chloride unresponsive or resistant.
Unresponsive.
Depending upon that will cause.
It is
give
not.
us
It
the
is. You are using the wrong word. You are there. It is not chloride resistant or chloride responsive. It is something else. It is saline responsive or saline non-responsive.
Okay, sir.
So metabolic alkalosis is divided into two groups. Either it is saline responsive or saline non-responsive. The saline responsive respond to saline, and the non-saline responsive are because of increased steroids or mineralocorticoids. Normally, whatever the cause of increased steroids, right? So if the urine chloride is less than 20, it is called saline responsive. If the urine chloride is greater than 20, it is not going to respond to saline. So that is the approach to metabolic alkalosis. Huh? So here we are getting respiratory alkalosis and metabolic alkalosis. Metabolic alkalosis is because of steroids and possibly because of hypovolemia. Huh? So this is the ABG diagnosis. Now the PF 22. Huh? Okay.
Yes, sir.
The O2 is 122. So are you happy with the O2
Yes, sir.
22? You want to decrease it or keep it like this?
No, sir. I'd like to keep it in the range of between 80 to 100, sir.
Yes, so you have to keep it a little lower. As per the newer evidence, newer studies, we do not want the oxygen levels higher than 92 to 96% in the ICU. Huh? So what
Yes,
is
sir.
for this, Dr. Razi?
Sorry, sir.
Why do you not want the oxygen levels to go up too high, beyond 100?
Sir, because higher oxygen levels can lead to more increase in the reactive oxygen species, which will cause more inflammatory damage to the system.
Very good. So a lot of work is being done as to what is the ideal target in the ICU. Huh? So
yes, sir.
Recently, just a year or two back, a COAST trial was done in African children, where they tested no oxygen versus giving oxygen patients of pneumonia. So saturation between 80 to 90% in children with pneumonia, they tested two groups. In one, they gave oxygen, supplemental oxygen. In the other group, they did not give any oxygen at all. And this was done for 48 hours, and they found there was no change in the mortality. Mortality was low across all groups. So we do know, yes, yet what is the ideal oxygen target, but definitely one consensus has emerged. Do not let PO2 go beyond 100. Because like you said very correctly, it leads to reactive oxygen species, and these can be damaging to the organelle in the cellular toxicity. Very good. Next.
So this is the X-ray done from the emergency department. So it showed no local lung pathology. However, the X-ray was taken in a supine position.
So what is your comment? Any other comment you want to make on the X-ray quality?
The exposure is not adequate, and the
so is this over?
It's a bit rotated, overexposed.
Overexposed.
Okay,
Patient was in supine, yeah.
Overexposed, rotated, absolutely. Anything else? Dr. Raki, one more feature is there. There is no lung pathology. Quality of
lung pathology, yeah.
There is no lung pathology. You said correctly, it is rotated, overexposed, because you can see the spine throughout. So that means it's overexposed. The clavicular heads are displaced. You know, the clavicular end of be equidistant from the spine. So it is rotated. And one more thing is there. It's a expiratory film. The diaphragms are pushed upwards.
Yes, sir.
Field. So there are the problems with the portable X-ray. The quality is very difficult. That is why ultrasound is becoming more and more important in evaluation of these patients, because the quality of portable X-rays in the ICU is quite pathetic, you know, because of the various factors like we discussed. Okay, next.
So this is the ECG taken. It shows a normal sinus rhythm with a rate of 107 per minute.
Any finding?
No, sir. Not that I can see.
V1, V2, V3 is normal. Something is there in V1, V2, V3.
A slight depression of the ST segment.
T is depressed.
Inverted.
ST
No,
is okay.
depressed.
There's nothing wrong
ST
with
is
ST.
okay.
T is
What is it?
depressed.
T is depressed. T is
T,
downgoing.
T is inverted. You don't say.
Inverted. Yeah, T is inverted.
So is that so? What does that mean? T is inverted in V1, V2, V3. What is the
Yes.
significance?
So inverted T. So they possibly because of
This is physiological. Inversion
yes,
of T waves in V1, V2, V3, and some other leads in isolation actually does not really mean anything. It is physiological. However,
okay, sir.
if it was an elderly patient with chest pain, it could mean something. It could mean something unstable angina or something. That's a different scenario. But in a young patient, V1, V2, V3 T wave inversion is physiological.
Normal.
Inversion by isolation, other leads also is generally physiological. Next.
Okay, sir. So, non-contrast CT of the brain done in the ER revealed no significant abnormalities. Put up the CT scan.
So does that rule out stroke?
Yes, sir. It ruled out hemorrhagic stroke, sir.
What about ischemic stroke?
So, recently onset stroke probably will not be seen in this
Since
CT.
this was done within the first 24 hours, right?
No,
Oh.
ma'am, the patient had been previously treated in a previous hospital. And so this is the CT done in our hospital.
So a lot of time has elapsed. So can you
Yeah,
rule
so-
out
Yes,
ischemic
yes,
stroke?
sir.
Yeah, we can rule out ischemic stroke also because it's not an
Yes.
acute.
So can you rule out all ischemic strokes, or maybe you'll be missing some ischemic stroke? So what is the difference in terms of picking up strokes between MRI and a CT?
So I say you're not audible.
I'm saying, in other words, what
Yes, sir.
can be picked up by MRI which is missed by CT?
Stroke, sir.
No, sir. Brain
Sorry.
brainstem
Okay.
strokes.
Okay.
Because brainstem is
Brainstem
not
strokes, yeah.
visualized sometimes. So brainstem strokes can be missed on CT. That's
Yes, sir.
up on MRI. Okay.
Okay, sir.
So what about the ultrasound? You did not comment on the ultrasound. You showed echo.
Sorry, sir. Ultrasound abdomen, sir.
Yes. Was it
Sir, I have not posted anything on the ultrasound because they had no significant findings on the ultrasound.
okay? There's no ultrasound findings. Say that's fair enough. And echo?
Sir, a normal echo
Okay.
was done, sir.
Okay. Carry on.
So based on the history and examinations, the following DDs were put forward by the emergency department: a toxic hepatitis or drug-induced liver injury, dengue hemorrhagic shock syndrome, CNS infection or acute encephalitis syndrome, a malignancy of unknown origin, and intracranial SOL and CVA.
So you see, all these do not seem possible to me. The only thing which seems possible is a serious infection or
Yes, sir.
acute encephalitis syndrome. That
Yes, sir.
one. So, Dr. Raki, you want to tell us why other possibilities are not there? Why only why it is not toxic hepatitis? Why it is not dengue? Why it is not a malignancy? And why it is not an intracranial SOL? Or
So toxic hepatitis, DILI and HILI, acute liver failure is ruled out because the previous investigations have already shown INR levels and all are less than 1.5. The OTPT levels are not so high. Even the direct bilirubin was less. The indirect bilirubin was high. So, acute liver failure is out of the question. Then dengue hemorrhagic fever. Maybe he had done the test, right, Rajdeep? You had have you?
So they had
It was
sent the
done
fever
maybe, yeah.
profiles.
Fever profile was
no. You don't go ahead. You have to discuss as per as what we have been talking about. So far we don't know about the dengue serology.
Yeah, we do not know. He has not
Why
yet
it is not dengue
told.
from whatever we have discussed. Dengue has thrombocytopenia.
Thrombocytopenia.
Does dengue
Dengue
have
has-
ecchymosis?
Yeah, fever also and
Yeah, it has encephalitis also. It doesn't
yes.
encephalitis.
So
Does dengue have encephalitis?
No, altered sensorium.
In dengue hemorrhagic shock syndrome, maybe patient might present with encephalitis.
So there is no shock here. We're talking about severe dengue.
Severe
No
dengue,
shock.
the patient will not have
So
any altered sensorium.
encephalitis does occur, huh?
Yeah.
Dengue encephalitis also occurs. Dengue can
Yeah.
any organ. It is not unusual. 5% of the patients of dengue coming to the ICU can present with encephalitis.
Encephalitis.
So encephalitis is possible, altered sensorium, and he has ecchymosis, he has thrombocytopenia, he has fever. So why is this not dengue?
So we'll have to do a dengue serology and confirm.
No, before the serology.
Before that.
Serology is all right. There is something we have already done which will tell us it is not dengue. In the investigations, we have done some investigations, radiology. What in the radiological investigations tells us it is dengue? So common.
Ultrasound, sir.
What do you see on ultrasound?
If there is platelet, there will be splenomegaly. Probably.
Dengue is not that common. Before that, you don't get dengue in assignment teams.
Very less, sir, here.
So you get
We get more of the tropical fevers, more
no,
common.
you get bilateral effusions, you get ascites, and you get gallbladder edema in dengue, serositis. There are no effusions, there is no ascites, there is no gallbladder edema, so it is unlikely. 95% of the patients with severe dengue will have evidence of serositis. Huh? Now coming to malignancy. So Dr. Rakhi, why is it not a malignancy?
So acuteness of the presentation
Yes.
plus
So acuteness of the presentation rules out malignancy. Malignancy will not suddenly present in 1 week like that. Stick before that. And why is it not an intracranial as well?
it would have shown in the CT brain, sir.
CT scan.
So
Yeah,
CT
generally it
brain
would
is more or
show-
less normal.
Yeah, so generally it would something will show and he'll have focal signs, some kind of focal neurological deficit would be there. So you agree, Dr. Raki, it would be a meningitis or encephalitis?
It may be an acute encephalitic syndrome. We'll have to rule that out by doing a CSF study.
What about meningitis? Do you think meningitis is more likely or encephalitis?
Acute encephalitis.
Why?
Acute patient had presented with fever, he had altered sensorium, and from the epidemiological part also presenting from this side of the country, we have more of the acute encephalitis syndrome like Japanese encephalitis or herpes simplex encephalitis.
Okay, fair enough. That is a geographical distribution.
Yeah.
But because you see so many of the encephalitis, my question to you is: do these patients come with so much thrombocytopenia and jaundice, etc.?
No, sir.
So that is very significant. Do they have
No.
ecchymosis?
They do not come with thrombocytopenia or
Ecchymosis,
any
right?
ecchymosis.
Yeah. So viral encephalitis is a disease localized to the brain. That is what I have also seen. So that is what you have also seen. It does not involve the systemic organs. Death occurs because of increasing ICT or involvement of the respiratory neurons, the brain stems, etc., etc. The disease does not go into a sepsis kind of a picture.
Sepsis kind of thing.
Yeah. So it is more likely to be meningitis.
Restricted to the brain.
Is having systemic thrombocytopenia, which may be because of DIC. So the patient may be in DIC also. Dr. Rajbir, do you agree?
Yes, sir.
The patient may be having meningitis with DIC.
Yes, sir. But then the PT-INR is not deranged, sir.
Does it have to be deranged, PT-INR?
At least.
Are you aware of any scoring system for DIC?
Sorry, so even if
So there is a scoring system given by the International Society of Thrombosis and Hematology, ISTH. Look it up.
Yes, sir.
It includes 4 or 5 factors. It includes platelets, PT, fibrinogen, D-dimer, and FDP. And each is given a point. So PT
Okay.
is normal, it is not necessary. Huh?
Okay, sir.
So some abnormalities have to be there. Okay.
Okay, sir.
By and large, it is an imperfect scoring system. The diagnosis of DIC is clinical. Huh?
We'll have
Okay,
to see
sir.
for the fibrinogen level and the
Yes.
FTP D-dimer
So you
levels
have to look
also.
at D-dimer, fibrinogen and all also. Normal PT can be there in DIC sometimes.
So the scores will be including those factors also, right, sir?
Definitely. Okay, next. Dr. Rekha, Reshu, any comments?
No, sir, not till now. We'll carry on.
Okay.
Yeah.
Okay, sir. So based on these findings, the patient was started empirically on the following treatment and shifted to the critical care unit. The patient was started on injection meropenem, injection levetiracetam, pantoprazole, ondansetron, and dexamethasone, and had been advised for 1 unit PRBC and 4 units RTP transfusion again.
So now look at the drugs that we have started, Dr. Rajdeep. Are you
Yes,
happy
sir.
with giving meropenem in a patient who's had seizure?
Sir, sorry, sir.
Are you happy giving meropenem in a patient who has had a seizure?
Meropenem does have some seizure potential, but considering that the patient had been already started on meropenem in the previous hospital, we had decided to continue with the injection meropenem.
I don't think that is a good policy. I would never give meropenem to a patient who is having seizures. You know, it will precipitate seizures. Is there any other carbapenem you can give instead of meropenem in these patients? What are the other carbapenems you know of?
Imipenem, ertapenem.
Anything else? Have you heard of doripenem?
Doripenem.
Sorry, sir.
Have you heard of doripenem?
Yes, sir. Yes, sir.
Dr. Rakhi, what is the advantage of doripenem in this?
So ferropenem, sir, is it a carbapenem?
Yes, doripenem, D-O-R-I-P-E-N-A-M, something which we don't use, but which is a very
Yes, sir.
useful drug because it has zero epileptogenic potential.
Epileptogenic potential. That's correct, sir. But do we consider them to be amongst the main carbapenem, sir? Ferropenem.
Yeah, doripenem, there is no head-to-head trial, but it has the same properties as the other carbapenems, but it does not cause seizures. It does go into the CNS. Okay.
Dr. Bansal, how many patients in general you have seen having meropenem-induced seizures?
It is frequent.
Encountered?
Imipenem is very frequent, and if the patient does not have a seizure prior, you can still go on with meropenem in a CNS pathology. But once the patient has had a seizure and you give meropenem, I'm not happy at all because this has led to seizures in my experience.
Because by few studies, evidence-based, not as such, they have seen that yes, among all the carbapenems, the imipenem is one molecule which has the highest seizure potential. Then is meropenem. So they have said the incidence of meropenem-induced seizures as such is quite comparable with other other family of the antibiotics as well, except for because they had seizure induced by imipenem quite high, but with meropenem when they had compared, because I just went through a very not recent, maybe in around 90s or 80s, some few case studies were there. So
no, that is okay. That is okay, Dr.
Theoretically, yes, they say that meropenem, the carbapenems are prone to seizures, but as such, because now we see as empirical therapy also in maximum of the hospitals, maximum of the units, meropenem is the drug of choice.
That is fine, Dr. Reshu. If there is no prior seizure, then meropenem is okay. If there is no alternative, you can still use meropenem. But if the patient has had a seizure, then this practice is not prevalent and there are no studies. Doripenem has no seizure potential. This is a point for a study actually. You comparing doripenem to meropenem in patients who had prior seizures and seeing the incidence of seizures in these patients. That's all the point I'm trying to make. I use doripenem.
Okay.
I used doripenem and did not have a recurrence of seizure. And meropenem does throw the patient into a seizure if he's had a prior seizure. That's the only point. Because it is known to cause seizures, definitely incidence is much lesser than imipenem. Imipenem, if you use, there's a very high chance of putting the patient into seizures. And especially if the patient is renal failure. Because once he's on renal failure, the drug levels, you don't know what you're dealing with. And uremia itself is a seizure-causing molecule.
So only oral formulations are available for ferropenem?
No, that is ferropenem,
Yeah,
F-A-R.
yeah,
I'm talking about doripenem, D-O-R-I. Read about doripenem.
okay, doripenem.
Yeah. So now coming to levetiracetam. So levetiracetam, what is the advantage of levetiracetam? It has been used. It is being used now very frequently as compared to other anti-epileptics. What is the advantage of levetiracetam, Dr. Razi, as an anti-epileptic drug?
So one advantage can be used in liver disease as well as to some amount in renal disease as well.
Very good. It can be used in liver disease. So other the drugs are, either metabolized to the liver or can be hepatotoxic, and we already have some derangement. What about, you said can be used to some extent in renal failure, meaning?
What we clinically practice is when a patient has a deranged RFT with a normal LFT, we prefer to shift the patient from levetiracetam to phospholate. But the theory suggests that levetiracetam can be easily used in the patients with deranged RFT as well.
Yeah, you modify the drug. Drug modification
Yes, sir.
is very clear. Huh? Okay.
Yes, sir.
Any other advantage of levetiracetam apart from this, what you have said? It has very few drug interactions.
Yes, sir.
It has very few drug interactions. The other anti-epileptic drugs have a lot of drug interactions. Huh?
Yes, sir. Yes, sir.
For example, meropenem has a drug interaction with valproate. It's very important. When you give valproate with meropenem, there's a very significant drug interaction. That becomes very important. So now coming to pantoprazole. So should pantoprazole be given to all patients in the ICU? Or there are some specific guidelines in this? Use of PPIs in the ICU.
So probably because what we practice is giving it regularly
No,
because
no. Don't. You are going to give the exam. This is no practice. What we practice and I practice. What does the literature say about use of PPIs in the ICU? First of all, it's justified in this patient. Tell me that.
Sir, the patient is getting steroids. So yes, sir, I would like to add a PPI because there will be more instances of stress ulceration in this patient.
Is there something more than steroids before steroids? The patient is bleeding. He's having ecchymosis. He has thrombocytopenia.
Thrombocytopenia.
Yes, sir.
So there are specific indications for PPI in the ICU. Every patient is not to be on the ICU, but any patient on mechanical ventilation should get PPI because they get stress ulcer injury. And if not on mechanical ventilation, there are specific indications, the foremost being a coagulopathy and 3-4 more. All patients are not to be given PPIs. What are the harmful effects of PPI? Indiscriminate use of PPI in the ICU. Dr. Raki, you like to comment? What are the harmful effects of PPI? So the harmful, yeah.
Yes, sir. Yes, you go ahead, Dr. Vans.
So the harmful effects of PPI is, what does PPI do? It alters the gut, the GI pH. It alters the pH. When it alters the pH, there's an overgrowth of gram-negative bacilli. Overgrowth of gram-negative bacilli leading to increased incidence of aspiration pneumonia by gram-negative bacteria. The second thing is because it alters the bowel flora, it leads to increased C. diff infections. So these are the two known side effects of PPIs. And the other thing is in cirrhosis patients. In patients of cirrhosis, if you use PPI indiscriminately, the bowel flora again is altered, there's increased gut permeability, you lead to SPPV. So, use of PPI is not just any kind of a drug, which is a multivitamin that you give for the health and benefit of patient. It has harmful effects. It should be used only if it is to be used. Now coming to ondansetron. This is again a drug which is used indiscriminately. What is the indication? Dr. Rajdeep, is there any indication here?
No, sir.
So this is a common practice in the ER. ER people will always put the patient on pantoside and emiside or whatever ondansetron molecule. So
Yes,
this is not to be given to all patients. In the ICU also, this is a standard prescription. Injection pentoside 40 OD, injection MSAT 4 mg TDS. So we have to be, each molecule is a toxin by itself. We have to be careful about what we write. Huh?
It also has some effects on the calcium metabolism also, sir, as far as I remember.
Which
Maybe
one?
the pantoprazole, sir.
See, pantoprazole in the acute setting have any effect on calcium, but pantoprazole also,
Long-term use.
yeah, not only long-term use, good you reminded me, it also has been associated with acute kidney injury.
Yes, sir.
So pantoprazole for some duration has been associated with acute kidney injury in the form of acute interstitial nephritis and also CKD, long-term use
CKD.
CKD. And PPIs in the long-term use can lead to hypomagnesemia and B12 deficiency also.
Yes,
So
sir.
these are some of these side effects. PPIs have a lot of problems. So you don't use,
Secondary hyperparathyroidism also.
not secondary hyperparathyroidism. That does not occur. Does not really affect calcium. It affects magnesium. It leads to hypomagnesemia. And in the acute setting, acute interstitial nephritis and AKI. That is very important. What you reminded me. So AKI is a newly recognized side effect of PPI. So that is very important. Okay. Now coming to blood transfusion. So, what is your hemoglobin that which you are transfusing?
7.6, sir.
So would you like to transfuse at 7.6?
Yes, sir. The literature suggests that patients of less than 8 should be given.
Okay, so 7 to 8 is the target. Are you aware of any meta-analysis published around 1 year ago, Cochrane meta-analysis, which looked at various studies and did a meta-analysis to show whether restrictive strategy or liberal strategy is helpful?
Sorry, sir. No, sir. I've not
So
gotten
there was a Cochrane meta-analysis done in 2021, which actually looked at all these studies. And the result was that the modality does not differ whether you use a liberal or a restrictive strategy targeting 7 to 8 hemoglobin.
Okay.
But the number of RBCs, packed RBCs used is less with a restricted strategy. So that's what this Cochrane meta-analysis found. Okay. Next, carry on.
So in the critical care unit, the patient was further examined, the previous findings collaborated, and the next set of blood and radiological investigations were planned for. The set of investigations sent were a C-reactive protein level, a procalcitonin level, a D-dimer level, a fibrinogen level, an FDP level, and a MCV and MCH for evaluation. Blood and urine cultures were also sent. The patient was further planned for an MRI brain, a CSF analysis, and an EEG.
So what is your interpretation of each lab value?
The CRP is slightly raised, sir. PCT borderline, D-dimer normal, a fibrinogen level borderline moderately raised.
No,
Or in the
fibrinogen
normal.
is increased or decreased? What is the normal?
Sorry, sir.
Fibrinogen.
Fibrinogen, sir, it is decreased, sir.
Yeah, it is. This is decreased fibrinogen.
Yes, sir.
Okay.
With FDP 1:4 ratio, MCV of 75.7 and MCH of 31.7.
So FDP 1:4. FDP 1:4 means what?
Sir, the dilutional ratio of it's more or less normal, sir. Fibrin degradation products.
Normal.
Yes, sir.
Okay. So and MCV?
It is low, sir. The mean corpuscular volume is low.
Okay. So looking at CRP and PCT, do they suggest any diagnosis? Specific.
So it rules out sepsis, sir, to some extent.
So is PCT or CRP diagnostic for sepsis if it's elevated?
No, sir.
So what are the current guidelines on PCT?
PCT is used for de-escalation of antibiotics rather than for diagnosing sepsis, sir.
Okay, so because it can have a lot of false positive and false negative.
Yes, sir. Yes,
so
sir.
it is not there in the surviving sepsis guidelines anymore as a diagnostic tool for
Yes, sir.
sepsis. Okay.
Yes, sir.
Now D-dimer is normal, fibrinogen is decreased, right?
Yes, sir. Yes,
so
sir.
does this FDP is normal and MCV is low. So MCV low actually points to some kind of a iron deficiency anemia, pre-existing anemia.
Yes, sir.
But we have to look at the peripheral smear. That is the final picture, right?
Yes, sir.
What kind of anemia this is. Now, if the fibrinogen is low, we may be dealing with DIC, correct?
Yes, sir.
Low fibrinogen are low, huh?
Yes, sir.
Okay, so the diagnosis of DIC is not so easy all the time from the lab test. It is a clinical correlation, but there has to be some abnormality in the coagulation parameters, which is there. Huh? So now I think we'll move on to the next slide.
So her urine RD results were as follows. The color was pale yellow, appearance clear, sediment was present, pH of 6.5 with a specific gravity of 1.015. There was no sugar, 1 plus albumin, with 2 to 3 pus cells in the high power field without any RBCs, cast or crystals.
So these pus cells are normal or increased? You mean 2 to 3?
2 to 3 are considered normal, sir.
Okay, up to what level is normal?
10, sir.
Up to 5. Up to 5 pus cells and up to 3 RBCs are normal in the urine. Okay, next slide.
Think it's different in males and female. In female, we consider 5 up till 8, and males I think up till 5. Because males, they have a less threshold. So males pus cells, if we get 5, it is considered to be UTI, to have a UTI. In females, if it is more than 8, then we consider it to be UTI.
Okay, I was not aware of that, but generally, you know,
Yes,
females, they can be contamination from the vaginal secretions. So that is probably the cause of increased pus cells. But
yes.
that is one thing. And the other thing is also in elderly patients, elderly females, often the pus cells are increased because of, you know, colonization, etc. So there are some factors, like you said, but generally,
The change in vaginal pH
yeah,
as well.
yeah, that's so. So there are some caveats. I agree. Next.
The patient was continued with the treatment started by the ER department. She was advised for 1 unit PIV transfusion and 4 units platelets as advised from the ER. She remained hemodynamically stable overnight. This was the first day when the patient presented to the ER department and then shifted to the critical care unit.
Okay, next slide.
On the second day of hospitalization, the neurological status of the patient remained static and she remained hemodynamically stable. However, the few lab reports were repeated, which revealed a hemoglobin of 7.4, a platelet count of 45,000. Considering these reports, the patient was further transfused 1 unit of PRBC and 4 units of platelets.
Okay, next.
On the day 3 of hospitalization, the neurological remained same. She remained hemodynamically stable, and the following lab reports were found: a hemoglobin of 7.2, a platelet count of 30,000, a raised bilirubin level of 5 with an indirect bilirubin level of 3.9 and direct bilirubin of 1.1. Urea
Okay,
of
so don't have to read everything. It's okay. So now platelets are falling and it's
yes, sir.
not increasing despite transfusing.
Yes, sir.
Going on. What do you think is going on in terms of hemoglobin and platelet?
Sir, there is hemolysis going on and there is increased destruction of platelets going on, sir.
So there is increased consumption or destruction going on of hemoglobin and platelets.
Yes, sir.
The hemolysis of the blood, right? And
yes, sir.
consumptive coagulopathy of platelets or destruction also of platelets going on.
Platelet going on, sir.
Along those terms.
Yes, sir.
Okay. So what is against DIC here? I told you it could be DIC. So what is the problem with DIC? Diagnosis of DIC. The bilirubin actually never becomes so high in DIC.
Yes, sir. Yes, sir.
So we are saying there's a hemolysis going on, right?
Yes, sir.
You know, in DIC also there can be thrombocytopenia. There can be some degree of autoimmune hemolysis can occur in DIC because of thrombus formation. But the bilirubin never becomes so high. So DIC is not really going to be there. Let's see as it goes on. Carry on.
Moving forward. So a series of EEGs were done 48 hours apart, which revealed no epileptiform activities. Dengue serology and other fever profiles turned up negative. All cultures returned negative. A CSF analysis was done, which revealed a total cell count in the CSF of 5, a sugar of 85 milligram per deciliter, a protein of 22, ADL level of 3.1 with Japanese encephalitis and HSV antigen negative. The color was colorless with no coagulum or deposit in the CSF analysis.
So is the sugar normal here?
Yes, sir.
Protein normal?
Yes, sir. More or
when
less
you
a
do-
negative, a normal CSF finding was seen.
So this is a normal CSF.
Yes, sir.
So when you do the CSF sugar, is there any other test you should also do simultaneously?
RBS, random blood sugar level.
Yes. So what is the cutoff here when you say low sugar? How much should the CSF sugar be of RBS?
It's 1/3.
40% or less. Okay, approximately 40% or less. And if this was bacterial meningitis, as we're thinking, what will
Yes,
happen
sir.
to sugar?
The sugar will fall down, sir.
It
It
will
will be
fall
low.
more.
And what about protein? What
Will be
protein in bacterial meningitis?
raised.
Protein,
Yes, Dr. Raki.
protein should increase, sir.
Increase,
Okay.
yes.
And ADA is done for what? For what?
So,
ADA?
for ruling out tubercular
Mycobacterium,
meningitis.
tubercular meningitis.
So what level is the cutoff for ADA in tubercular meningitis?
A CSF level of less than 11, sir.
Very good. So 10, 11, whatever, more than 10 indicates tubercular meningitis.
Yes, sir.
AEHSV is normal and coagulation. So now coming to cells, there are 5 cells.
Yes, sir.
Is this normal?
Yes, sir.
What is the normal cell count of a CSF? In a normal CSF, do you see cells? And if you see cells, how many cells are normal? Dr. Raki, normal CSF cell count?
So around 5, sir. 5 to 10.
Yes. 0 to 5. 0 to 5
0
is
to
normal
5.
cell count. So now this patient is receiving steroids. Does giving steroids have any bearing on the cell count?
Increase.
Do steroids increase, decrease, or have no effect on the cell count?
There should be increase in the cell count in the CSF.
Dr. Reshu, any comments? Steroids and CSF cells?
Basically, here in CSF, there is no much changes observed by the use of steroids. Just for the number of cells, there is one comment from my side that the number varies from where the CSF have been taken. If the CSF have been collected from the ventricles directly, the cutoff is 0 to 3. If more than 3 cells, it's considered to be infective. And if it is taken from a lumbar puncture, it's 0 to 5.
Okay, so fair enough. Now, the point I'm trying to make is that steroids actually decrease the cell count. Okay, so in this patient, it's possible that the cell count is something like 25, 50, 100, and it has become 5 because of steroids. And that is because steroids have an immunosuppressant effect. So they suppress the inflammation in the meninges, and the cell count becomes falsely low. So you can have a meningitis or an encephalitis, more of an encephalitis rather, because the meningitis picture is florid with cells. But if there are not too many cells, they can be suppressed to a normal range by steroids. And this occurs also in HIV patients. So 2 conditions in which you can have meningitis or encephalitis with a normal cell count is on steroids or immunosuppressant drugs or HIV. This should be borne in mind. This is a caveat to interpretation of CSF cells. So here, because sugar is also normal, protein is also normal, bank normal. So I don't think there is a problem with the CSF despite steroids. So your meningitis is ruled out then, Dr. Azib?
Yes, sir.
Okay. So we rule out meningitis. Viral encephalitis was already unlikely in view of systemic involvement. So let's then. Now there is no CNS pathology unless we get something on the MRI, which probably you must have done.
Yes, sir. Okay, sir. So the MRI again revealed no significant abnormalities. More or less normal MRI was seen.
Okay, is this T1 or T2 image?
Yes, sir.
No, can you say whether this is T1 or T2? There is T1 and T2, right?
Yes, sir. There are T1 and T2. This is, I
So
think,
one should know the little basic about MRI, right? I know MRI and all go into the field of neuroradiology and neurology, but with it being done so frequently, one should have some idea. Is this T1 or T2?
so as far as I remember, this is T1, sir. T1 flare. Diffusion T1 flare.
So the easiest way to remember is to look at the CSF. The CSF in T1 is white, in T2 is black. Huh?
Okay, sir.
So that way you can remember. And it helps
Okay, sir.
T1 and T2 show different areas better. That is why you do T1 and T2 both. Huh? So some ideas should have T1, T2 flare. So different kind of imaging is there. DWI. DWI is very important for stroke imaging, acute stroke when in the first few hours. When the patient comes in 2-3 hours, then DWI and all these things. The little idea has to be there in working in the neuro ICU or with stroke patients and all that. Okay, next ICU, next slide.
Okay, so based on all these reports and investigations, the negative as well as the positive, a new differential diagnosis of autoimmune vasculitis was put forward, and this following set of investigation are planned: a peripheral blood smear, a serum LDH level, ANA reflex assay, C-ANCA and P-ANCA profile, direct and indirect Coombs test, and an apply antibody test.
So now, autoimmune vasculitis. Huh?
Yes, sir.
So, were other people also involved, physicians or nephrologists or hematologists?
Yes, sir.
So, what kind of autoimmune vasculitis they were thinking of?
Sir,
Dr. Reshu, you want to comment on this? How did the vasculitis come into the picture here?
Because the platelets count were still falling after repeated platelet transfusion, the other differential diagnoses were ruled out. So this was another differential diagnosis which came into play after discussion with the physician team, by the nephrologist as well. So then
So
that's
here,
when
I would just like to say, so autoimmune vasculitis presenting acutely normally is either venous granulomatosis or polyarteritis nodosa microscopic, which are called ANCA positive vasculitis. But the predominant, organs involved in these vasculitides which come to the ICU is one kidney and second lung. They'll have a renal failure with a positive urine sediment, RBCs, WBCs, and they'll have lung involvement in the terms of lung hemorrhage or lung infiltrates, hypoxia. So both the lungs and the kidneys are normal. So the differential of vasculitis seems less likely. What we are having is actually autoimmune hemolytic anemia with thrombocytopenia. That is what we are having, and that is what is to be investigated. And when you get a picture like this, a peripheral blood smear becomes very important, a retic count, and looking at whether there is any fragmentation or schistocytes being formed in the peripheral smear. So, because that gives rise to the concept of a thrombotic microangiopathy. And next slide, Dr. Rajbir. Rajiv?
okay, considering this diagnosis, the patient was started on a high dose intravenous steroid regimen of methylprednisolone of 1 milligram per kg.
Next slide.
On day 4 of hospitalization, the patient developed multiple episodes of generalized tonic-clonic seizures, leading to worsening of GCS, following which the patient had to be electively intubated and ventilated. Her vitals were as follows: a heart rate of 110 per minute, a BP of 118/78, SpO2 of 98% with a face mask of 5 liters per minute, a respiratory rate of 24 to 26, GCS of E1, B1, and M3. This was post-seizure. So, the ABG was done, which revealed again the same thing: a pH of 7.43, a PCO2 of 24.3, a PO2 of 118, a lactate level of 3.6, and a bicarb level of 25.
So why the lactate has increased? I believe it normal earlier.
So probably because of the seizure, sir.
So how does seizure lead to increased lactate?
So there's going to be a hypoperfusion and increased consumption, increased energy expenditure in the muscles, leading to increased lactate level.
Okay. So what are some of the other causes of increased lactate? One is seizures, and then of course sepsis. Apart from this, what other causes you know which can cause increased lactate?
Uh, uh, Primary lactic acidosis, drug-induced, and liver disease.
Which drug?
Metformin most commonly causes lactic acidosis in chronic alcoholics.
Very good. Metformin. What else?
So liver disease itself will cause lactate increase.
Okay, very good. What else?
I already mentioned sepsis. Any hypoperfusion issue can cause increase in lactate.
Great. Okay, then thiamine deficiency can cause. Huh?
Yes, sir. Yes, sir.
Alcoholics are deficient thiamine or patients malnourished. Then epinephrine infusion. Very important is adrenaline infusion. You give adrenaline infusion, the lactates can increase. Huh? So these are some of the causes of increased lactate. So lactate has to be seen. Many causes can cause lactate. Where is lactate metabolized in the body when it is produced?
Liver, sir.
Is there any other organ which is
muscles, sir? Muscles also.
Liver and muscles.
Muscles.
Anaerobic metabolism. The muscles.
Liver, see, lactate is produced in the liver, but where is it consumed? What is Cori cycle? Or let us say, wait, what happens to the lactate that is continuously produced? 1500 millimoles of lactate are produced in 24 hours daily by the body in normal metabolism, mainly by the muscles and some by the other tissues. And what happens to this lactate? Why does liver disease cause increased lactate?
There is imbalance in the the Krebs, the anaerobic metabolism was how do I put this?
So the liver actually converts the lactate to glucose.
Yes, sir.
Huh? It's called Cori cycle. Huh? So when the liver is diseased, the lactate conversion does not occur. Thereby the lactate. Okay.
Okay, sir.
And part of the lactate, which is produced daily around 20%, also goes through the kidneys. It is just filtered out by the kidneys also. So there can be some elevation of lactate even in renal failure patients.
Okay, sir.
Yeah, it contributes to some extent. But it mainly lactate metabolism, one should know lactate metabolism as intensivist. Little bit biochemistry.
Okay,
next.
A repeat NC non-contrast CT of the brain was done to rule out any further structural defect, so which revealed no bleed.
Okay, next.
A few lab reports were sent which revealed a drastically falling hemoglobin level of 4 gram per deciliter, a platelet count of 26,000, raised serum LDH level of 2,330, a raised total bilirubin level, raised urea level of 83 with normal electrolytes.
So, you know, the hemoglobin is falling, and we said there are two causes of falling hemoglobin so acutely. One is bleeding and one is hemolysis. Was a GI-scopy done any time?
No, sir.
Steroids and all. Huh?
Endoscopy was not done, sir.
Endoscopy was not done, sir.
So ideally, one should also do the endoscopy, you know, because he's on steroids, he has dropping hemoglobin.
But a stool for occult blood test was done, which was negative, sir.
Okay, but one should also do the endoscopy. Yeah. Anyway, assume that occult blood was negative, so there was nothing there was no GI loss. So obviously, he's hemolyzing and platelets are dropping. So peripheral smear becomes very important here to see what is going on. Next.
Yes, sir. So a peripheral smear which was previously sent revealed this thing: a mildly neutrophilic leukocytosis without any immature cells or blasts. RBC predominantly normocytic, normochromic RBCs with degree of basophilic stippling and polychromasia. 30% of nucleated RBCs per 100 RBCs were seen, WBCs were seen. Severe degree of thrombocytopenia. So this was the peripheral blood smear findings, sir.
So, Dr. Rathi, does this indicate reticulocytosis? Dr. Raki, you were talking about reticulocytosis.
Yes, sir.
Is
So
it
reticulocyte
compatible?
counts were not done, but
Yeah.
reticulocyte counts were not done, sir. But red cells with degree of basophilic stippling and polychromasia were there.
And
So
there are 30% nucleated
30%
RBCs.
nucleated RBCs were there.
So does this indicate hemolysis? Is this compatible?
Yes, sir.
Huh?
Yes, sir.
So
Yes, sir.
nucleated RBCs and polychromasia are more or less like reticulocytosis.
Reticulocytosis.
They are
So
release
those are
of,
equivalent. Yes, sir.
they are release
So this
of
indicates
immature,
hemolysis.
yeah, they are release of immature RBCs
Immature RBCs.
on the marrow because the RBCs are being broken down. So there is an increased stress on the marrow to produce RBCs. So immature RBCs are released, nucleated RBCs are immature RBCs, and polycythemia is a feature of reticulocytosis. So we have this peripheral smear. What is very interesting is that they have not commented on schistocytes, cells and schistocytes. You know, we are now considering something which is causing thrombi. You know, there's a consumptive coagulopathy, and consumptive coagulopathy can lead to hemolytic anemia and thrombocytopenia. So if there are schistocytes or target cells, one would think of a consideration of TTP.
TTP.
Since the LDH is going high. So they should have mentioned that no schistocyte seen, no helmet sign seen. That is very important here. Okay, so ANA reflex assay you have done, which is strongly positive. So does that mean she has SLE?
So most likely,
Dr. Reshu, you please comment on this reflex assay. I have not done this reflex assay. I know ELISA and IFA. So this reflex
No.
is a good
Reflex assay, yeah, it includes everything. We can rule out all the vasculitis. Does not only concentrate only on SLE, but other vasculitis syndrome as well.
So it's a pan autoimmune
pan,
body.
yes. It's a pan. The SRL Renbexi, they do it quite often. So we can get the
So this includes the ANA, Pianka, Cianca, and all those antibodies.
Pianka, Cianca, we have to do separate. If the
That's
ANA
a separate test
separate,
we have to do.
If we get the ANA reflex positive, then we advise for Pianka, Cianca.
So here, you know, ANA positive 4+ actually means something like
quite significant, right?
Yeah, it is very significant. But here the problem is, my problem is that they have not said whether this is IFA or ELISA in this reflex assay. The actual two test, this is a pan assay kind of a thing. So they have called it a reflex. The two tests are either IFA or ELISA for ANA. And one generally ends up doing IFA because that is the most accurate. Even ELISA is accurate.
They do it IFA only, that fluorescent, they do it that only. ELISA, they don't do it. They do the NA reflex is done by the IFA testing only. So that's why it is more accurate. And significance is 1:4 is quite significant here.
No, 4+ is very significant. This
yeah.
NA, if IFA is being used, so that means she's NA positive, right? And
right.
Okay. So Coombs test and test for Pianka, Cianca negative, APLA antibody negative. So what is APLA antibody done for, Dr. Rajiv?
Sir, this is to rule out antiphospholipid antibody syndrome, sir. Catastrophic.
Okay, catastrophic antibody.
To rule out vasculitis. He had initially given the diagnosis for autoimmune vasculitis, right?
So that is Pianka, Cianca, right? That is negative.
Yeah.
So Pianka, Cianca is for autoimmune vasculitis. That is negative. So APLA is also negative. So you are ruling out vasculitis. You are ruling out antiphospholipid antibody
syndrome.
CAPS.
And yeah, CAPS is the catastrophic antibody plus syndrome. And then ANA is strongly positive. So probably there's an autoimmune basis to this. So in the setting of this battery of tests, one has to consider autoimmune process. And let us see what else you have now. Next.
So based on the symptoms and investigation report, a provisional diagnosis of thrombotic microangiopathy, most likely TTP was put forward. So the points in favor of this were the clinical presentation, a plasmic score of 6, there was no renal involvement, the Coombs test was negative, no evidence of DIC, and the APLA antibody was negative. But the only factor that we could not do was the Adams TS13 assay, which is more or less confirmatory for the diagnosis of TTP?
So, Rajiv, one statement I don't agree with you here is no renal involvement. Renal involvement is not against the diagnosis of TTP. In fact, it is a frequent finding. Neurology manifestations and renal manifestations are a frequent finding of TTP. Probably you mistyped it. It occurs because thrombi formation occurs in the vasculature of the kidneys. So renal failure is a very frequent finding. It is a pentad actually. Fever, anemia.
So if I may say, the renal involvement is there, but if there might be there, but with a very low creatinine levels. The creatinine levels are usually less than 2. A similar spectrum of TMA is the hemolytic uremic syndrome, where the renal finding is more predominant, sir.
I agree.
As compared with the complement mediated TMA, sir, so renal findings are lesser in the TTP group.
I agree. Hemolytic uremic syndrome has more of a kidney involvement, but the pentad is a pentad for TTP. Fever,
Yes, sir. Yes, sir.
anemia, jaundice, neurology involvement, kidney involvement.
Kidney involvement, yes, sir.
Involvement is less, definitely, but definitely, again, there is a renal involvement component. It may or may not be there. The pentad is not always there.
Yes, sir.
So you cannot say that. Now, I would have this stage, we don't have a Adams 13, which is a diagnostic test for TTP. Okay? So
Yes, sir.
why the pathologist specifically, are you seeing any cystocytes and helmet cells? That is a very important feature.
Yes, sir.
What
We had when the previous study had come, we had specifically asked the pathologist whether they could
And it
see
was-
or identify any cystocytes there in the smear. So which came out to be negative. They could not. They did not.
Then
Right,
this was
Rajiv, as well as I remember.
Yes, we had actually double checked this entire PBS like twice. So there were no evidence of cystocytes or helmet cells.
Okay. So I will take it at that. But the problem is, Dr. Reshu, with due regards to your pathologist, she has reported a MCV of 76 and then reported normocytic normochromic cells in the peripheral smear. So
Yes,
what was the expertise of your pathologist? With due respect, I would be a little.
I know, I
Yes.
understand.
Okay, you saw that MCV, they reported
Right.
Yes.
that is severely microcytic, and then
Yes, sir.
she is reporting normocytic normochromic. So we rely on these people with due respect to our ancillary colleagues, microbiologists, but often we end up in this problem. Huh?
I hope there are no pathologists, and in future also, when you upload it, no pathologist should listen to this.
Yeah. So we face this problem all the time. These things happen, correlation between the labs and the clinicians. So
Actually, sir, we had a hematologist also recheck the slide as far as I remember. So
Okay,
he
so,
also didn't see any cystocytes.
So this is compatible. Some patients may not have target cystocytes and helmet cells. Some patients, a small fraction. Normally they would have. So here, we assume a diagnosis of a thrombotic microangiopathy. Most likely, it is a TTP picture. Diagnosis is TTP. So Adams 13 assay, if it's less than 10%, would lead to a confirmatory diagnosis. It's not available everywhere, Adams 13 assay. So what happens in TTP is, and what is happening here is, in TTP, there is increased thrombosis. There's increased thrombosis because there is decreased Adams 13 assay. Now, when there is Adams 13 in sufficient amounts, von Willebrand factors, which are normally secreted in large multimers, are broken down. And this prevents the interaction of von Willebrand factor with platelets to form thrombosis. When there are no Adams 13 molecules or deficiency, then these large multimers of von Willebrand factors lead to thrombosis by interaction of platelets. So this is widespread thrombosis. There's a widespread thrombosis in the vasculature, and when the platelets are traversing through, or the RBCs are traversing through the circulation, they hit against these thrombi. And this fragmentation and destruction of platelets, and distortion and fragmentation of your RBCs. That is why you get helmet cells and misshapen cells and cystocytes. And these distorted RBCs then cannot go through spleen, and the spleen removes them. So there's a continuous destruction and hemolysis of the RBCs. And because bilirubin comes from hemoglobin, and hemoglobin comes from destruction of RBCs, there's increased bilirubin production. And when bilirubin is produced in the spleen and other organs, it is secreted into the bloodstream as unconjugated form, not as conjugated. And excess unconjugated bilirubin is not being able to be taken up by the liver because it is in excess. That is why you get unconjugated hyperbilirubinemia in TTP or any hemolysis. So that is in a nutshell the pathogenesis of TTP. Now, there are other conditions also which lead to a thrombotic microangiopathy. TTP is not the only one.
Yes, sir.
These conditions are APLA, or they can be HELP syndrome if she's pregnant. You never told me about the pregnancy test. What the pregnancy test?
Sir, UPT was done in the emergency, I guess, sir. But
Yeah, whatever. Okay. Anyway, HELP syndrome or preeclampsia can also lead to a similar picture. Then cancer patients,
Yes,
they have cancer thrombi floating around, microthrombi, they can also cause, and sometimes scleroderma crisis.
Even SLE, sir, patient's ANA reflex was very high. Even she could have had.
So you see, TTP has precipitating factors or other conditions associated with it. And one of them is SLE. SLE can be associated with TTP.
TTP.
That is one reason. And the other thing is, the pathogenesis of TTP is very complex. Sometimes the autoantibody generation can lead to breakdown of Adam's molecule. It can be idiopathic or precipitated by other conditions. So, that's why probably being ANA positive led to worsening of TTP. TTP has precipitants, and SLE is one of the conditions associated with TTP. So that is my take on this. That is why probably ANA was positive.
Sir, one question, sir. So the MCV was done on day 1 of admission, that is from the ER. Okay, sir. And the patient had received 2 units of PRBCs. Sir, and the PBS was done on day 4, sir. Can this blood transfusions cause a problem in this peripheral blood smear?
Yeah, so this will cause a problem. So then she has to report dimorphic anemia. She will, in a peripheral, she has to report microcytic and normochromic.
Okay, sir.
Hemolysis actually leads to large sized cells.
Yes, sir.
So the reporting is not entirely satisfactory as far as I can make out. So that becomes dimorphic anemia, where you have small size RBCs as well as large size RBCs.
Okay, sir.
Next.
Okay, sir. So with the
comments? Dr. Reshu?
No, Dr. Bansal, carry on. No, Dr. Bansal, carry on.
So with this diagnosis of TME or TTP put forward, the family was counseled for the need of total plasma exchange urgently. And as a bridging measure, the patient was started on a plasma trial for 3 days, along with IV steroids and folate supplementation. Over the next 2 days, the patient remained on ventilatory support with no improvement in neurological status, but hemodynamically stable. The hemoglobin, the patient had received 1 or 2 units of PRBC in this period. So the hemoglobin level on day 4 was 4, day 5 was 7.1, and day 6, 6.5. The platelet count was steadily decreasing from 26,000 on day 4 to 11,000 on day 6. The LDH level rose from 20,330 to 3,187, with a total bilirubin level rose from 5.7 to 9.7 to 7.1.
Okay, so carry on. One thing.
Day 7.
We'll just go back.
Sorry, sir.
We'll just go back. So the urea is going up. It was 59 when she came. Now it's 83, 88, 97. Creatinine is not rising. So this is called a disproportionately high urea.
Yes, sir.
The patient is not actually in renal failure, but the urea is elevated, but the creatinine is normal. So does it have any meaning? Or what?
So probably patient's fluid status needs to be checked. The patient might be dehydrating.
So one is dehydration, but she's been receiving a lot of blood, etc. So it is slightly unlikely. Maybe she's dehydrated, you never know. What else can cause this?
Increased catabolism, sir.
Very good. So if the catabolism is high, there's an increased breakdown of proteins, and protein breakdown leads to high urea.
Yes.
Anything else which is, she's not in a catabolic state as such, right? This is not
No, sir.
surge
No.
or trauma. So there's no catabolism. So what is going on? Which is the answer here? Why the urea is high? Because of steroids.
I'll probably.
Steroids
Okay, sir.
also cause the protein catabolism,
Okay, sir.
likely. And you have not done a GI endoscopy. GI
No, sir.
common cause.
Bleeding.
Bleeding. One increased
Bleeding
bleeding.
can
It
also
is
cause.
very much possible there was some bleeding going on because
Mm.
very low, there's ecchymosis, the evidence of extra GI bleed, and she's on steroid. So it's
Yes,
possible
sir.
some oozing going on in the gut also.
But so the hemoglobin levels were continuously like increasing from 4 to 7.1
No,
to
the hemoglobin
6.5.
levels are all over the place. Sometimes you're
Mm.
transfusing, sometimes you're not transfusing.
Not.
They want
Yes,
to make out
exactly.
what's going on. Next.
On the day 7, the patient was finally put on the first session of total plasma exchange, and 1 plasma volume was exchanged. The patient still remained on ventilatory support but was hemodynamically stable. Post the total plasma exchange, the patient showed drastic improvement in her neurological status. Her base GCS on day 8 was E3 VT on M5, and she was planned for weaning and extubation. Her lab parameters were improving gradually, and she was planned for another session of total plasma exchange the next day. So on day 7, the hemoglobin was 6.7 post total plasma exchange, and day 8 it was 7.3. The platelet count was 58,000 with a rise to 85,000 on day 8. The LDH level dropped to 1,419 and to 721 on the next day. Total bilirubin dropped to 4.9 with indirect bilirubin of 3.4. The TC count remains static between 11,500 and to 10,900 between these days.
Okay, so she's improving, huh?
Yes, sir.
Okay, next slide.
On day 9 and 10, the patient was put on a second session of total plasma exchange. Post TP, the lab report shows marked improvement. Her neurological status improved to a GCS of E4 and M6, E4 VT M6, and there were no further episodes of tonic-clonic seizures. The hemoglobin increased to 9.1 on day 10, with a platelet count of almost 170,000, a LDH level of 724, a bilirubin level of 5.5 with indirect bilirubin of 3.9, and urea of 69. So there was marked improvement in the platelet counts as well as in the hemoglobin level.
Okay. Next.
She was successfully weaned off on the ventilator support after 3 days of ventilatory support while carefully being monitored for her neurological, hemodynamic, and blood parameters. And she was discharged after complete resolution of neurological symptoms 15 days after being first admitted with a final diagnosis of thrombotic mitral angiopathy, immune TTP, most likely secondary to SLE. So this is the pattern of her blood reports from day 11 onwards. We see the hemoglobin gradually rose to 11.2 on the day of discharge. The platelet count after the second session of TTP was 1,86,000, which gradually increased to 2,27,000 on the day of discharge. Her LDH levels almost neared normal, with a bilirubin level of 2.9 at the day of discharge.
Okay, next slide.
Coming to the discussion, sir.
Okay, so now you have done the plasmapheresis, and definitely that has helped, and that is the treatment of choice for TTP. How does plasmapheresis help in TTP?
So the main principle of plasmapheresis is to remove the excess antibodies present in the body, in the plasma. So when these antibodies are removed, the immune reaction to the blood cells is gone, and the cells are able to survive, and the proliferation is there. So the destruction is reduced.
So one is this removal of antibodies.
Yes, sir. Yes, sir.
So what else do you do with plasma? What did you give for replacement? Were you there?
Sir, we use equal units of FFP and albumin, sir.
So when you are giving FFP, what are you doing?
We are replacing the von Willebrand factor, sir.
Not
and the clotting factor.
You are replacing the Adams 13.
Adams 13. You're replacing the Adams 13.
enzyme.
So that the von Willebrand can be cleaved.
So what you are doing actually is, when you are doing the exchange, you remove the large multimeres of one bilirubin factor which are responsible for thrombosis. And you're
Yes, sir.
removing the antibodies, which are probably responsible for the pathogenesis in this case.
Yes, sir.
Give the plasma FFP, you are giving Adams 13.
Yes, sir.
The principle of plasmapheresis working so nicely in TTP. In fact, TTP is one of the diseases in which plasma exchange is of primary therapy. It has a lot of importance and very high response rate, though they get
Yes, sir.
lapses. Huh? So,
Yes, sir.
so that is, so what are the other indications where plasma, your plasmapheresis works or is indicated? Some important indications.
See the other indications, sir. So this one, what is this thing? Right now,
So we talked about liver disease. So can
Yeah.
you talk about liver disease? Any indications?
acute liver failure, ACLF.
ACLF.
Okay. So which acute liver failure? Any acute liver failure you would? So acute liver failure patients who are managed conservatively. Those who are going to transplant, not those patients. It helps in these patients. And it helps, especially in Wilson's disease related acute liver failure, it has a very nice outcome. And in acute on chronic liver failure. So how does it help in these patients? How do you think it would help in these patients?
By chelating out the excess copper in Wilson's disease.
So that is generally in acute in liver disease, it helps by removing the toxins. See, liver has functions of detoxification of various molecules in the body.
Yes, sir.
So when the liver is non-functional, various toxins, including bile acids, and so many others accumulate. And when you do the plasma exchange, these are removed. And you replace with fresh albumin, which is also helpful in these patients. So it has a beneficial effect in ACLF and in those patients of ALF who are managed conservatively, especially Wilson's. This is evidence-based, and this is very important to know because this is ICU related. And apart from those conditions, then they can have some patients come with hyperviscosity, high platelet counts, high TLC counts. So their leukophoresis or plateletpheresis, which is a modification of plasmapheresis, is done.
Yes.
Viscosity
AIDP
syndrome-
patients.
Sorry?
AIDP patients also might.
Yes, AIDP generally we give IVIG because plasma is invasive procedure and the results are the same. And a lot of autoimmune conditions it can be used because it removes the antibodies.
Yes, sir.
Antibodies are removed. So it mainly used for immune processes, good Pasteure's disease, etc. And
Yes, sir.
it's used for hypertriglyceridemia induced pancreatitis, acute pancreatitis.
Lipopheresis, sir.
In a while you get patients with very high triglyceride levels, which is causing acute pancreatitis. So there also it is used. So it has some indications which are laid down class 1, class 2, class 3 by the American Association of Plasmapheresis. So one should be aware of some of the indications, and TTP is a foremost condition. So Dr. Reshu, you want to tell how this was done actually, the process? You were involved with this plasmapheresis?
We had involved a nephrologist and Dr. Razik was actively involved here. We took the calculation totally by like replacing the whole of the plasma.
So just show the calculation, Dr. Razik. Please tell the calculation. How do you calculate?
So plasma volume is calculated by in liters, calculated in liters as 0.07 into weight in kgs into 1 minus hematocrit of the patient.
So this is one plasma exchange, right?
Yes, sir.
So how many is
This
that?
is one. So the literature recommends 1 to 1.5 plasma exchange on every alternate days till for 3 days minimum.
Yes. So that
Till
varies
remission.
actually from disease to disease.
Yes, sir.
That is the normal thing. Each session should have a 1 to 1.5 plasma exchange volume.
Yes, sir.
Then how do you replace this? You remove the plasma, then how do you replace this?
So we have replaced with equal volume of FFP and albumin, sir.
FFP and
Fresh frozen plasma, fresh frozen plasma and albumin, sir.
anything else you can use for replacement?
We can also go for crystalloids as well. We
Yes.
can mix with crystalloids.
Yes. So
if we
depending
are
on
afraid
the
of it.
yes, absolutely. So depending on the decision, the condition, you replace with FFP or normally NS plus albumin is used. FFP more for specific hematology conditions, especially if there's a coagulopathy or certain other situations. What are the drawbacks? What are the side effects of plasmapheresis? Dr. Rajiv?
The most common is going to be infection, hemodynamic instability,
Infections because of what?
because of it's an invasive procedure, sir. If
Okay.
sterility is not,
So that is just as CRT, right? Okay.
yes, sir.
So what else can cause infections? Transfusion of FFP. So using FFP is prone to infections. Huh? That is one
Yes,
of the
sir.
advantages of using FFP. It can lead to infections. Okay. So one is infections. What are the side effects?
Then can be hemodynamic instability
Okay.
during the process.
Okay.
There can be volume overload as well.
Very good.
Uh,
Okay. So these are some of the side effects. Something like CRT side effects. Sorry. Yeah. So and what are the drawbacks? What are the drawbacks in treating a patient with plasmapheresis?
So the major drawback that we had to encounter is the cost effectiveness of the procedure. So,
Okay.
so this process requires an additional filter, which is a bit costly for a setup like India.
Okay. So cost is always a factor. You know, in India is a developing country, but there are patients who can afford also. So the cost is a relative factor. Everything is costly. The ICU itself is costly. You know, those things are, have to be borne in mind. Very important is drug removal. Very drug removal. You know, these patients often they're getting steroids, they're getting immunosuppressants. Rituximab is a drug advised for your TTP, and there are no clear guidelines or estimates of how much drug is removed for many drugs.
Yes,
so drug is a problem even in CRT patients, right? We do not really know the dose, and it is even more so for plasmapheresis. Because when you
plasma
molecules, the toxic molecules, they are also being produced and re-entering the circulation. So drug therapy has to go on to stop the actual process. The plasmapheresis is the cleaning process going on, but at the same time, you have to hit the disease at the root. And for that, immunosuppressants or some drugs will be going on. And no clear guidelines are there on drug levels and drug therapies. These patients. And the other thing is the laboratory tests, the timing of the laboratory tests, because there's a dilution factor. So the laboratory test values also get altered to a great extent.
Okay, sir.
So these are some of the things. I think I don't have anything more to say. So the final diagnosis was thrombotic microangiopathy, the cause of which was TTP, and TTP was probably related to SLE.
SLE, yes, sir.
Idiopathic TTP or TTP secondary to drugs. Secondary to many conditions. One of them is SLE. It can also be because of drugs and some other conditions. And the hallmarks of TTP are fever, jaundice in the form of indirect bilirubemia, and you get thrombocytopenia and CNS and renal.
And
of course, everything may not be there, but this is a classic penta. And the treatment is plasmapheresis along with steroids or rituximab. This is the crux of TTP. So, Dr. Akhi, you want to comment anything or ask anything?
So in our case, like the difficulty was when there were no cystocytes present in the PBS. So like we had a lot of difficulty in initiating the process of TP, the therapeutic plasma exchange, because since we had not done the ADAM TS13 test also, even the PBS was not significant, even though it was showing increased hemolysis.
So here, Rakhi, the approach is actually you are having hemolytic anemia.
Yes, sir.
So what are the causes? You approach it clinically. The hemolytic anemia has very few causes in the ICU. So either it is drug induced, or it is blood transfusion related, or it is autoimmune.
Autoimmune.
Or microangiopathy. This thrombotic angiopathy is also called microangiopathy.
Microangiopathies.
So once you approach that clinically, you have to rule out any drugs, right? You have to rule out blood transfusion, and you have to rule out autoimmune process. Coombs test was negative.
Coombs test was negative.
Okay.
The patient had already received many units of blood in the previous hospital also. And even in our hospital without patient received platelets, I think almost 8 units.
Yes, so considering everything, your blood transfusion related is ruled out, because if it was blood related, you will be hemolyzing all the time. Patient would have died by now, if you're not doing anything. So blood transfusion is ruled out. Drug cannot be ruled out entirely. Okay, drugs can never be ruled out. Okay, but so drug-induced hemolysis is always possible, but one has to look at the clinical profile, how it started, how it's going on. So this is not exactly like a drug-induced hemolysis, and you are having thrombocytopenia also along with it. So when you rule out the other causes, you are left with only microangiopathic hemolytic anemia, and the LDH is going very high, which
Yeah.
of TTP.
Plasmic score was high, sir, for this
Yes,
patient.
so I'm not aware of the plasmic score, but the LDH was very high. LDH is
Yes.
on increasing. Along with that, you have CNS symptoms. You are having CNS symptoms. So all the clinical features are fitting in with your TTP.
TTP.
Thing is, normally 90% of the patients you would see schistocytes or helmet cells. But they may not be there. Literature
They
also
may not be there. Yeah.
not be there sometimes, rarely. So and Adams 13 has to be done, those are limitations of your center, or probably in Assam, Guwahati is not being done, I don't know. So that is the limitation. Otherwise, you would have sent the Adams 13, it would have come less than 10%. Diagnostic test is Adams 13.
The other
the
limiting
Adams 13
factor was the
basically
It was
the cost.
advised. It was because of the cause that it could not be done.
Yeah, so that is the way to approach it. You have to explain to the family, take the consent, and do the plasma
Yes.
and see the response. That's all. So often we have to do these things, make a clinical diagnosis, explain to the family, take the consent, and go ahead. That's all. So, Dr. Rajdeep, any questions?
no, sir.
Okay. You have done well, huh? You have presented very nicely, answered very nicely, and wish you all the best for your exams.
Thank you, sir.
Very nice. Dr. Reshu, your comments, ma'am.
None, sir. Thank you so much. But it was a challenging case for us as well, because how we came to the diagnosis, it was basically a very good team effort from all. Thank you.
So I thank everybody.
Thank you, sir.
If there are any questions, please, we'll wait for 2 minutes. Any questions from the audience? So there are no questions. So thank you, Dr. Reshu ma'am, and Dr. Raki ma'am, and Dr. Rajdeep, and thank your ICU and all the people involved with this. And with that, I think we will come to the end of the session. Thanks, everybody.
Thank you so much,
Thank you,
sir.
sir.